Welcome to the Kanski lecture series, Eyelids part 7, and in this part we are going to discuss about the different diseases of the eyelids. So now we are going to discuss about some allergic disorders. Acute allergic edema. So basically allergy is something which is due to sensitivity to some normal thing that is present in the environment. Acute allergic edema. Acute allergic edema is usually caused by exposure to pollen or by the insect bite and manifest with the sudden onset of the bilateral boggy periauricular edema, often accompanied by the conjunctival swelling, which is called chemosis. Treatment is often unnecessary, but the systemic antihistamines are sometimes given. So this is a case of an acute allergic edema. So basically it is something which is due to the pollen or something due to some insect bite, and what you can get is a boggy edema around the eyelids, and there can be the chemosis of the conjunctiva, and you can treat it with just systemic antihistamine. Contact dermatitis. So basically contact dermatitis is when the thing is in contact with the eyelid, and anything, like it can be an antibiotic as well, or it can be anything, eye drops, cosmetics, that when comes in contact with the eyelid causes the reaction. Contact dermatitis is an inflammatory response that usually follows exposure to a medication such as eye drops, cosmetics, or metal. An irritant can also cause a non-allergic toxic dermatitis. The individual is sensitized on first exposure and develops an immune reaction on further exposure. The mediating reaction is type 4 delayed type hypersensitivity. Signs consist of the lid, skin scaling, angular fissuring, edema, and tightness. There may be chemosis, redness, and papillary conjunctivitis. Corneal involvement is usually limited to the punctate epithelial erosion. Treatment consists primarily of avoidance of the allergen exposure, provided it can be identified. Cold compresses provide symptomatic relief. Topical steroid and oral antihistamines can be used but are rarely required. So basically, what are the signs of the contact dermatitis? The patient can give a history of something in contact with the eyelid. But if it's not, you can identify that it is a contact dermatitis with the scaling, and there can be the fissuring, and you can see the tightness of the eyelid, and this is the contact dermatitis. And how do you treat it? You can treat it with the just cold compresses. You can use antihistamines, you can oral antihistamines, you can do the topical steroid as well. In case of the conjunctival reaction, basically in the conjunctiva, with any type of allergy, the most common type of the conjunctivitis is the papillary conjunctivitis. Remember that. Atopic dermatitis, eczema, is a very common idiopathic condition typically occurring in patients who also suffer from asthma and hay fever. Eyelid involvement is relatively infrequent, but when present is invariably associated with generalized dermatitis. Thickening, crusting, and fissuring of the lids is typical, and staphylococcal blepharitis, vernal or atopic keratoconjunctivitis are also commonly present. Herpetic blepharitis and keratoconjunctivitis are more common and more severe in patients with atopy, eczema herpeticum. Treatment of the lid fissure is with the emollients to hydrate the skin and the judicious use of the mild topical steroids such as hydrocortisone 1%. Uncommon ocular association include keratoconus, cataract, and retinal detachment. So basically with atopy, there is the patient is generalized sensitive, and the patient also have the systemic features as well. He may have a hay fever, and basically in the atopic dermatitis you will feel that skin is dry. In such patients are very starting from the lids are prone to the staphylococcal blepharitis, and then when we go to the conjunctivitis, they are very prone to VKC and AKC. vernal or atopic keratoconjunctivitis, and any disease is usually severe in such kind of patients. So what you do is you hydrate the skin as much as you can. And some of the other association is the keratoconus. Why? Because there is itching associated with atopic dermatitis, and when you itch and you rub the eye, the patient is predisposed to the keratoconus, and cataract formation may occur due to the steroid use, and retinal detachment can also occur. Immune related inflammation, dermatomyositis. Dermatomyositis is a chronic inflammatory disorder of muscles which can present in an acute or chronic fashion with muscle weakness and a skin rash. In children, about half develop eyelid swelling and heliotrope rash. In adults, it may be associated with ovarian, breast, or lung cancer, or as an autoimmune response. The condition is treated with systemic steroid or immunosuppressive medication, methotrexate or azathioprine. So basically it is a autoimmune reaction in which there is a muscle weakness and the skin is also involved. This is not a very important topic, but just remember it. Bacterial infections. Now very important is the bacterial infections of the eyelid. One is an external hordeolum, very important, which you encounter in your OPD most of the time, is the stye. Stye is basically the infection of the lash follicles, and when the lash follicles is infected, there is the patient present us with the pain and a nodule formation on the eyelid. An external hordeolum or stye is an acute staphylococcal abscess of a lash follicle and is associated gland of disease that is common in children and young adults. A stye presents as a tender swelling in the lid margin pointing anteriorly through the skin, usually with the lash at the apex. Multiple lesion may be present, and occasionally an abscess may involve the entire lid margin. Treatment involved topical, occasionally oral antibiotics, hot compresses, and epilation of the associated lash. So this is the case of the stye. You see that there is a nodule formation that is associated with the lash follicle. Impetigo is a superficial skin infection caused by the Staphylococcus aureus or Streptococcus pyogenes. Typically affecting children, involvement of the eyelid is usually associated with infection of the face. Painful erythematous macule rapidly develop into the thin-walled blisters, which then develop into the golden yellow crust on rupturing. There may be fever, malaise, and local lymphadenopathy. Treatment is with topical and sometimes oral antibiotics. Beta-lactamase resistant and preventive measures to reduce the transmission, and the condition is highly contagious. It is particularly dangerous to neonates, contact with whom should be avoided. So this is an impetigo. You can see that there is an infection of the skin. So basically impetigo is caused by the Staphylococcus aureus or Streptococcus pyogenes, and it is like a process. It starts with the macule, then blisters are formed, then crusting form, and then they rupture. And treatment is with the systemic antibiotics. Then there is erysipelas, which is also known as St. Anthony fire, is an uncommon, acute, potentially severe dermal and superficial lymphatic infection caused by the strep pyogenes. So very important, it is basically the infection of the lymphatics, which is in the superficial skin. Diabetes, obesity, and alcohol abuse are the predisposing factors, and inflamed erythematous plaque develop. A well-defined race border distinguishes erysipelas from other forms of cellulitis. Complications such as metastatic infection are rare. Treatment is with oral antibiotics, but recurrence is common. So this is a St. Anthony fire. You can see the plaque formation on the skin, and the treatment is with the systemic antibiotics. So necrotizing fasciitis is basically the necrosis of the skin that occurs, and there will be the blackish discoloration of the skin as well. Necrotizing fasciitis is a rare but commonly very severe infection involving the subcutaneous soft tissue and the skin with associated rapidly progressive necrosis. It is usually caused by the strep pyogen and occasionally strep aureus. The most frequent site of involvement are extremities, trunk, and perineum, as well as post-operative wound sites. Unless early aggressive treatment is instituted in the form of surgical debridement and a high-dose intravenous antibiotics, death may result. Redness and edema are followed by the formation of the large bullae and blackish discoloration of skin due to necrosis. So in this case, you have to debride the area because it is a rapidly progressive disease, and you also treat it with the systemic antibiotics. So next is a viral infection, very common, molluscum contagiosum. You may encounter this in OPD very often, and basically these are multiple umbilicated nodules that are present on the eyelids, and these are usually in children, usually present in with such cases, and it is a viral infection. So let's get started. Molluscum contagiosum introduction. Molluscum contagiosum is a skin infection caused by the human-specific double-stranded DNA pox virus that typically affect the otherwise healthy children with a peak incidence between the 2 and 4 years of age. Very important, it usually present in children among 2 to 4 years of age. Transmission is by the contact and subsequently by autoinoculation. Multiple and occasionally confluent lesion may develop in immunocompromised patient. Histopathology show a central pit and lobules of hyperplastic epidermis with intracytoplasmic Henderson-Patterson inclusion bodies that displace the nuclear remnant to the edge of the cells. So there is a inclusion body which is known as Henderson-Patterson body that displays the nuclei to the side of the wall, and the bodies are small and eosinophilic near the surface and large and basophilic deeper down. So you can see figure 2.39. It is showing the histopathology showing lobule of hyperplastic epidermis and a pit containing intracytoplasmic inclusion bodies. So these are the pit. So this is a pit, and there is a hyperplastic epidermis, and these are the inclusion bodies. So in the superficial, it is eosinophilic near the surface, and it is smaller eosinophilic, and in the down it is basophilic and larger. Diagnosis: single or multiple pale waxy umbilicated nodule develop. White cheesy material consisting of infected degenerate cells can be expressed from the lesion. Lesion on the lid margins may shed virus into the tear film and may give rise to the secondary ipsilateral chronic follicular conjunctivitis. Unless the lid margin is examined carefully, the causative molluscum lesions may be overlooked. So these are the nodules. These are usually whitish. When we look that there are some certain umbilicated nodule that is present, and these are the lid margin nodule that often can be overlooked, and you can miss it. And associated conjunctivitis associated with molluscum contagiosum is the follicular conjunctivitis. Treatment: spontaneous resolution will usually occur within a few months, so treatment may not be necessary, particularly in children, unless complications such as a significant secondary conjunctivitis are problematic. Options include shave excision, curettage, cauterization, chemical ablation, and cryotherapy and pulse-style laser. So basically, it is a self-limiting disease. You can just observe it, but if the symptoms are very much, you can just excise it, use cryotherapy, or do laser ablation. Tip: in a patient with a chronic follicular conjunctivitis that does not respond to topical antibiotics, look for molluscum contagiosum involving the lid margin. Herpes zoster ophthalmicus. Herpes zoster ophthalmicus is a common, generally unilateral infection caused by the varicella zoster virus. It is discussed in detail in chapter 7. So basically, the herpes zoster is unilateral and involving the dermatome of the trigeminal nerve. Herpes simplex introduction. Herpes simplex skin rash result from either a primary infection or reactivation of the herpes simplex virus previously dormant in a trigeminal ganglion. Prodromal facial and lid tingling lasting about 24 hours is followed by the development of the eyelid and periocular skin vesicle that breakdowns over the 48 hours, although typically confined to the single dermatome and with individual lesions that are often similar in appearance. The distribution of the herpes simplex rash contrasts with the sharply delineated unilateral involved herpes zoster ophthalmicus. There is a commonly an associated papillary conjunctivitis, discharge, and lid swelling. Dendritic corneal ulcer can develop, especially in atopic patients in whom skin involvement can be extensive and very severe, which is known as eczema herpeticum. So basically, in a case of the herpes simplex rash, the patient may present the tingling sensation in the face for like 24 hours, and then it is followed by the vesicle formation, and then it is the breakdown, and it is not they follow the dermatome, but they can be bilateral and they can cross the midline as well, as compared to the herpes zoster, which is strictly a unilateral infection. And in this case, the dendritic corneal ulcer may form, and in a case of a atopic patient, it is very severe. So it is called eczema herpeticum in that case. In many patients, the inflammation will gradually settle without treatment over about a week. If the treatment is necessary, a topical acyclovir cream 5 times daily for 5 days, or oral acyclovir, famciclovir, or valacyclovir antiviral agents can be used. Antibiotics, for example, amoxicillin, erythromycin may also be required in patient with secondary bacterial infection. This is particularly common in eczema herpeticum. So basically, you treat it with the topical antiviral cream, or you can just first we just observe it, but you can use the acyclovir cream as well, and can use the oral antiviral as well. So that's it for the eyelid part 7. See you in the next lecture.